Excellent. I believe we're now live. So welcome everyone. Good morning. Welcome to this meeting of the South West London CCG Governing Body. The meeting is being broadcast live and it's being recorded, so it will be uploaded onto the South West London CCG website after the meeting. Members of the public can ask any questions live and we'll do our best to answer them as part of agenda item 10, which is set aside for public questions. We've had apologies from Nick Ireland, who's the Director of People's Services at London Borough of Sutton. And we've got the declaration of interests available in everyone's papers. And so we've also got a glossary and acronym buster available on the South West London CCG website, but I will remind everyone as ever, please to try and not use NHS jargon, and we'll try and speak as intelligibly as possible. I'm taking that people have had the opportunity to read all the papers beforehand, so we won't be going through them all in detail. We'll just be getting a summary of the key issues. So I confirm we're now quorate and can start the meeting. So can I just check whether the declarations of interest that we've got are accurate and up to date, and anything for any particular agenda item that I need to be aware of for this meeting? No? Okay. So let's go straight on then to the minutes of the last meeting. We've got the minutes from the 6th of October meeting. Rather than do a page turn, there's quite a few of them. Can I just check, are there any key issues of accuracy in the minutes that I need to be aware of that we might need to correct? Liz.
Thanks, Andrew. Could it be minuted that on behalf of the 6 Health Watches, I asked about the CCG Staff Survey, which we recognised that it's primarily designed for clinical staff, but we did note that there were several scores that had diminished over time, and we noted that there is going to be further discussion about what lies behind the staff responses. But nevertheless, could I have it minuted that we did raise some concerns about these fairly low scores on some of the points, and that these scores had diminished over time. So that was item 4 on the agenda, Liz, was it? The workforce update? It's the minutes from the 6th of October, and it's page 9 of 141. Yeah, so we've not got a question from you noted, have we? But you did ask a question, is that correct? I did, yes, I did. Okay. Yes, so Pippa is minuted as raising a point, and Pippa Barber in relation to it, but the Health Watch point isn't minuted, so if it could be, we'd be grateful. Thanks. Yeah, okay. I think we should take that away and make sure we accurately reflect what was said. Thank you. Okay. Any other issues of accuracy for the minutes? No. So let's assume that we're going to go back and check that and amend it to include Liz's question and the response to that. If we do that, are people then happy to approve these as an accurate record of the meeting? Yes? Okay, so they're approved with that caveat. So let's go straight on to the Chair and Accountable Officer reports. So you've had that in writing, but just to pull out from me, the one item in my part of the update is the community diagnostic hubs, and that's really the fact that we've got £10 million to invest in a new community diagnostic hub to start with at Queen Mary's Hospital, Roehampton, because that was where we were able to get on and deliver it. Obviously, there's a huge amount of work going on about how we use that hub and how it interfaces with a number of other locations around the whole of South West London. And there's work going on to secure funding for future diagnostic hubs, potentially at Croydon and at St Helier Hospital. And obviously having a community diagnostic hub at St Helier Hospital was part of the Improving Healthcare Together plan anyway, so that makes a huge amount of sense. What I have been really impressed about as part of the work done by the group looking at this is they've looked at a lot of the data we've got, health inequalities, and have really taken that into account in their planning of both the hub services, but also when they're thinking about the satellites and the location of the future hub. And I know Jonathan knows all the detail on that if there were any questions, but I've been very impressed having seen some of the work in that group. Sarah, did you want to just pull out your 2 items from your part of the report?
Yes, so firstly, just to highlight that it was Black History Month in October, and I just want to say how inspirational many of our staff have been in some of their stories, and definitely for those that have access, they should definitely go in and look at some of the stories that we have heard from our staff. Finally, on the ICS update, because I'm just going to do this briefly, we have been doing some listening events around the governance, particularly for the partnership. There is a process that's ongoing around how we develop the governance for the future ICS, and we have set up a governance oversight group in which a number of our lay members and yourself, Andrew, are involved. So the process is ongoing. We expect to still see more guidance, and we'll report back and bring decisions through to the governing body as those become the right timing for those.
Thank you, Sarah. So are there any questions for myself or Sarah? Susan?
Yes, it was just about the ICS development. Obviously, we're doing work to embed the voluntary community and social enterprise sector into the ICS. And I just wondered, maybe this is something I could pick up with Charlotte when we talk at our engagement steering group about how that impacts on our engagement and communication strategy moving forward. That is the key part as well to us of it as providers, as well as also in helping us to engage with local people. Is that your expectation, Sarah?
Yeah, can I bring Charlotte in actually, and because she's doing a lot of work on this at the moment.
Hi, yeah, so we're doing a very broad content engagement strategy, and I think so we've taken it to the community engagement steering group, as Liz and Bruno will know, and we're sort of going on the road around key groups around South West London, and what we're doing is bringing in the ICB content engagement strategy as well as the ICS content engagement strategy. So we really build on a kind of grassroots listening to our communities, and then acting accordingly from April onwards, and a lot of this will be borough based because we have community content engagement groups at borough level who are very linked in with Place and with South West London programmes. So I think it's building on what we're already doing, but obviously we've got an opportunity from the 1st of April to really boost that and kind of improve what we do and do something different. And I suppose just to also talk about the listening events that have happened over the last few weeks, sort of talking to key leaders and stakeholders about the future of the organisation and doing that in an iterative way. But happy to talk offline around some of the detail of that.
Thanks, Charlotte. Really helpful. Pippa, can I bring you in?
Thanks, Andrew. I just wanted to ask a couple of questions about the diagnostic centres. So it was really good to see, and it's great that there's some investment coming in locally for that. So questions. I wondered if we had any idea around timescales for certainly some of them. And the other thing was, are we including a development of a workforce plan to support delivery of these?
Jonathan, did you want to come in on that?
Yes, I can. Thanks, Andrew. So on timescales, we're already well underway with what we wanted to put in place at Queen Mary's, Roehampton, which is the first phase of the programme. And I think in relation to the next phase, obviously we need to through a process of engagement with people and the wider community, decide where those sites are and where their hub services that will have the sort of full array and panoply of what we would want in a diagnostic hub, everything from MRI through CT and point of care testing, ECGs, echoes, imaging, etc. And spokes, because there are also envisaged to be some spoke sites. It's a programme over a number of years, Pippa, so we would need to make proposals to secure capital to support each phase of that programme over coming years, and we're working through that now. But I think realistically it's probably a 5-year programme to get to where we need to get to on diagnostic hubs. And that very much aligns with the point on workforce. So as part of our planning for this year and into next year, we really need to think how we deploy staff most effectively around diagnostic services, because obviously a highly specialist workforce. We already have the examples of the work, for example, we did around echocardiogram that you're well aware of in Kingston and St George's, to try and share workforce, and we need to think about how we do that and also develop new people with new career paths, as it were, into supporting us around the diagnostic capacity issue, because that's one of the key limiters on us at this point in time. So both those issues have been worked through. This is a long-term programme, but I'm really pleased, as Andrew has said, we've secured initial funding to get the Queen Mary's Roehampton element off the ground, and this helps us, and it also helps through very challenging winters, because we will have the capacity to keep more of the elective pathways green and open, because we have dedicated diagnostic capacity away from the main hospital sites. So hopefully that's a bit broader than just your question, but hopefully I've tried to answer that too, Pippa.
Thanks,
very helpful.
Karen, did you want to come in further on the workforce bit?
I did. I mean, just to say that I met this week with the London team of Health Education England to talk particularly about how we could utilise their expertise going forward, and diagnostics is one of the areas that we particularly mentioned. They have great workforce planners and redesigners that will also help. So we're going to put them in touch with the diagnostic leads that's running the community diagnostic centres, and just see if we can connect those two pieces of work as well.
Your hand went up as part of the discussion on community diagnostic hubs. So
no, sorry, mine was bouncing back February on the listening. So I hold that diagnostic hubs.
Hold that, and I'll check back with Pippa that you're happy with the response, Pippa.
Very happy. Thank you both. Really helpful.
I'll actually bring Bruno in then, because his hand went up before yours. I just thought you might be coming in on this one, Bruno.
Thank you, Andrew. And I think you partly answered my question with your introduction on the diagnostic hubs, but presumably the intent is to try and make sure that there's kind of extra access across Southwest London CCG ultimately, although, you know, it's going to take 5 years or whatever it may be. Presumably that's the case. The other thing is I just wanted to flag the fact that the CCG had got this investment in embedding to enable it to embed the VCSE in the ICS, and I just wanted to flag that up because I think it's particularly welcome and necessary.
Thank you, Bruno. Yeah, so to confirm that the plan is to make sure we've got coverage across Southwest London for diagnostics, and I agree with you. Welcome the funding for the VCS. Jonathan, did you want to come back?
Just to confirm, Bruno, that's one of the criteria nationally as well about how we're addressing health inequalities through this programme of work. So it's a really important part of it. And also to share, as part of the work they've been doing across London, there's been a number of engagement events to think about how diagnostic hubs operate and function. We followed that up in Southwest London, also with a number of surveys, and I understand there's also some listening events planned from talking to the programme lead on this too, to make sure that they reflect the needs of the population in Southwest London.
Thank you, both. Dagmar, shall I bring you in now?
So just to bridge, first of all, thanks as well. Dr. Clark came to the Overview and Scrutiny Committee on diagnostic hubs, so really appreciated to keep the councillors informed. So that was last night in Merton. Thanks for that. My question was going back, Sarah, just to the listening events around the ICS and particularly their place-based governance of interest locally. So really appreciated the listening events. A big thank you for pulling those off. Just a little bit better understanding of timelines, because obviously not all councillors could be there, and there is more that we are doing locally. So help us a little bit about the timeline of collating the feedback, and then who ultimately has to sign off whatever arrangements will be agreed. Thank you.
Okay, so the local discussions carry on. I don't think, and particularly the place discussions, there's still more time to work through those. Ultimately, what we will need to do is pull together proposals, which will then be discussed with leaders across the system before we go through any sort of formal process. And we hope by Christmas to have kind of completed that timeline. Ultimately, and then the RIG board, which is where the system comes together in South West London at the moment, Recovery and Transition Board, will make a recommendation through to the CCG, who is the only statutory body, and then the CCG will then make a recommendation forward to NHS England and I, who make the decision. So we don't make any decisions locally, we make recommendations and proposals, and that's the way we will work. But what we want to do is get kind of a view from the whole system, and to try and get something that is reasonably agreeable to the system as a whole.
Great, thanks very much.
Thank you. Right, no more questions. So are we happy to note that? Good. Shall we go on then to the first item for approval, which is the GP IT strategy? Karen, handing over to you.
Thank you, and I think let me just quickly text Sam because I think she's joining us, but we're a bit ahead of time. So just by way of explanation, over the last couple of years we brought together the different ways in which GPIT was traditionally provided across the 6 CCGs, and we did that to improve the service that was being received, but also the stability of IT systems in general practice. The previously devolved and variable approach to IT meant that we had less effective IT infrastructure, equipment and software in GP practices, and that has led to a differential performance and investment in the service across practices. And that meant that we didn't have the same services or capabilities across our boroughs. We also had a main IT partner in 5 of the 6 boroughs who was not providing the level of service that was required. And that meant that we had problems with the service, but also misalignment of expectations on both sides. So in 2019-20, we brought together the GPIT into a single function so that we improved that service, and we established a dedicated team. And in the paper, it describes the 4 key areas that we originally asked them to focus on. But at not very long after, we then saw COVID, and the team and the newly created function supported primary care with the response to COVID, and through that saw a rapid rollout of equipment and technology to support new and different ways of working. And I suppose we're now at the point where we've used the last 2 years to create a stable platform for IT and primary care, and the clinical leads on the board may wish to comment on that. But we're now at the point where we need to move on to agree the strategic priorities for GPIT going forward. And Sam and her team have engaged extensively with borough clinical chairs, their teams, practices, to determine those priorities that are important locally, as well as considering the national and local priorities that are also required. And the output from those and the engagement exercises that we've undertaken have brought together the strategic priorities that you see in the document that's with you today, as well as the programmes that are going to take forward those work. And I suppose just to be clear what the strategy is and what it isn't a digital strategy. The purpose of this strategy is to make sure that GPs and their practice teams have access to the latest systems, equipment and ways of working to support them to provide the very best care for patients. And that's whether it's face-to-face or on the phone or via video conferencing. So it's the technology and the services in the background, providing primary care staff with the tools and the equipment to support things like the digital interfaces between primary and secondary care. And by that, I mean things like electronic referrals, exchange of clinical correspondence between clinicians, test ordering, etc., as well as then establishing data that may be used in the future for population health management. And I suppose just the final thing to say is there is a requirement for investment in the paper, and it's important to know that we don't have all that investment secured today, but we will continue to bid for funding. And over the last year, I think the team have been successful in attracting £6 million worth of funding into GPIT, and we will continue to do that on an ongoing basis to cover the investment that's required. But we also need to use the benefit of scale in an ICS to improve also what we do and the value for money from in terms of what we receive. So that was my way of introduction. I will hand it over to any questions.
So, I think what I would say is we know historically there was quite wide variation between the different boroughs in GPIT support, and this has had a huge amount of GP and practice more broadly input into it, and I know we've taken it through the borough chairs with the senior management team as well, and generally the thought was it was really welcome and moved us forward a long way. So really well done to you and the team, I would say. Can I open it up to questions and comments? So I do now have an order of hands on my screen, so I'll go in order. Paul, do you want to come in first?
Yeah, thank you, Chair. Thank you for that, Karen. I just wanted to get an understanding from you, as you mentioned in your sort of outline of the report. Obviously, with COVID coming along last year, as you will recall, there was significant investment in infrastructure and hardware around IT across the whole system, not just GPs. But with that investment, Karen, I mean, how has that, impacted the GPIT strategy and the rollout? Has it accelerated it? Has it changed it? And I think the second point was, just looking at the paper, I wasn't quite clear what the sort of the timeline of the strategy program was. Maybe if you could just illustrate that in a little bit more detail, please.
Karen, shall I get you to hold the questions and then you can probably, because there'll be some themes, I think, and then you can respond to them all in the round. So let me take a few more. Susan, shall I bring you in?
Okay, a slightly different tact, needless to say. So it looks like you've got really good stakeholder engagement in coming up with the sort of priorities, and as you say, a focus really on hardware, networking, IG solutions, really. But the reason we're doing it, presumably, is to improve the patient experience and the patient's outcomes. And I just wondered if there was some way that you could present a narrative which shows what this will mean to patients and the public. So some vignettes or case studies will show what will be different once this is in place as you develop it. Because I can see that this document itself doesn't necessarily need patient and citizen engagement. The solutions as part of your bigger digital strategy will. And I suppose it's just seeing how this connects in with that, and that we can see that we're putting and able to articulate the benefits of it, this investment in terms of outcomes for people. Thank you.
Thanks, Susan. Good question. So Naz, let me bring you in.
Sorry, computer just a bit slow. I just want to, I do welcome this because I think it's very long overdue. Two questions. One is around Kingston historically have had a really good service from their provider, Your Healthcare. And the first thing is just want to make sure we're not going to get a degradation of service. The second question is around have we made sure that we've captured all the COVID consequences in the past 18 months as part of this strategy? Otherwise, we're going to lose an opportunity, mainly to do with things like elective care, outpatients, restoration, recovery, etc. So just making sure that that bit's been captured.
Thanks, Naz. Bruno? Bruno, you're muted. You were talking
Sorry about that. Sorry. Yeah, whilst the programme is very much about hardware, software and service infrastructure, how has the kind of picture around what it can and can't enable been looked at? Because I'm just thinking of the kind of access that other partners might need to NHS systems in order to work in partnership with them, like the voluntary sector, and also the behaviours around the way that GPs hold their or have their practices around enabling access to those who would otherwise be digitally excluded. In other words, there are balances within the thing of computer-based and telephony and those kind of things. So how have those kind of areas been looked at? I'm sorry, I'm not making myself very clear, but that's the best I can do.
Yeah, information sharing and digital exclusion.
Yeah.
Liz.
Thanks. My point builds on Susan's really, and we discussed this at the pre-meeting, and it is about, I mean, we appreciate this as a technical paper, but that the leads through into how it then affects service delivery. And the particular phrase that I picked up on page 30, was a statement that an impact of delay is that the GP service will remain anchored to a physical location. So, and that got me wondering, you know, what thinking underpinned that statement, and therefore what implicit model of service delivery is actually underlying this technical paper, which I appreciate is something that needs further discussion outside this meeting. But picking up on Susan's point, that having some vignettes on how this can improve the patient experience, because of course I guess we're all aware that nationally that has become quite a sensitive topic, and the balance of remote consultation and face-to-face is quite a sensitive topic at the moment, and that therefore if concerns and anxieties can be allayed by, you know, spelling out actually what benefits that this can have for the patient experience, that is something worth thinking about.
Thanks, Liz. And I'm sure Karen will respond to that. I think we need to keep in mind what this isn't. So it's the GP IT strategy, not the digital strategy or the GP access strategy. And I think probably that bit is referring to people being able to log in to access the system when they're having to work remotely, rather than a strategic intention around that. I'm sure Karen can cover that. There's our two hands.
Yeah, no, so, you know, I've probably been the biggest critic of the IT in South West London. And I can say, you know, the benefit of having come together is the levelling up from a Croydon perspective, which has been really welcomed. The infrastructure required massive overhaul and support as well. And, you know, I think we're now on par with everybody else. You know, we started the pandemic consulting on our mobile phones because we didn't have the hardware or the technology to do otherwise, and systems falling over all the time. So, you know, I think thanks to that. The second is that being involved in developing this strategy as well has been a new approach involving everybody from grassroots to clinical leaders and management as well. So that approach has been welcomed as well. And I think the other element to this is about outcomes, and I think we need to do more to be able to highlight to people the benefits of some of the different ways of working, rather than get into the national arguments in the media at the moment, which is kind of you know, one-sided. But I think in terms of the paper itself, it's welcomed, and it can confirm it's been involved a lot of people, and I don't have an angst anymore.
That's really good to hear, Agnelli. Thank you. Can I bring Patrick in?
Thanks, Andrew. So just to reiterate that point Agnelli made about the recognise the speed of response from the team that enabled the adaptation to COVID and having to continually adapt that as time goes along. So I think we do need to recognise that. Also, just in response to sort of Susan and Liz's comments, the expansion and how patients will experience benefit. So investment in additional roles and reimbursement in the to expand the team to allow a wider spread of services to the patient. That is dependent on this programme. We have to make sure they've got access to kit that enables them to be able to link into the practices. And the other immediate obvious one, there's a whole load of other clinical benefits too, but also looking at long-term conditions and case finding and using this strategy in conjunction with data sets and local authority to actually identify long-term condition patients who are historically perhaps vulnerable to the inequality issue, because I think it helps us to focus resource and delivery of service to that population. And the other thing I would flag within this is that clinical leadership is much more at the heart of our IT development than it has been historically, and the detachment of our IT teams in the past has caused some disruption, conflict within the service, and I think we're in a much better place now than we were before.
Thank you, Patrick. Right, so I'm going to hand back to Karen. I can see we've also got some is on the call as well, and she was the kind of architect of a lot of this. I've never heard, not just in this meeting, but outside this meeting, such warm praise for a GPI IT strategy as I have for this one. I think it just reflects the amazing amount of work that's gone into this and the really incredible engagement, because I think that's where it really stands out, is the amount of work that's been done with really understand any response to that. So I guess I want to call out Sam Ball on that, because you're on the call now, so really well done. But Karen, over to you.
And I would echo that. I think we've been incredibly fortunate to have Sam and her leadership with GPRT, but more than that, she's actually created a team that have created the culture of IT that thankfully both Patrick and Agnello and others are seeing today. So really well done. I'm going to try and wrap up all of those questions. Remind me if I forget any of them, but let's have a go. So in relation to kind of how do we get information out, etc., the information sharing agreement actually is picked up through the digital work, Bruno. So the plan through the digital programme is to make sure that information that has been agreed by patients is shared through our partners, and that's through the digital programme. The timeline for the strategy is 2 to 3 years. It depends really how much of the funding we receive, and therefore how quickly we can do it, Paul, but probably 2 to 3 years is our current assessment. Naz, that we have no intention of coming away from your healthcare, but we do have to work more closely and use our scale as much as we can, because one of the things that we said, wasn't it, is that we didn't want any deterioration in service. This was about making things a lot better. And Sam and her team work really closely with your healthcare. But as we move forward as an ICS, we do need to think about, is there a different way that we should do things at scale? But we're not looking to make any changes that would deteriorate the service. Just in terms of some of Liz's points, I think in terms of the comment about anchored into kind of physical buildings, I think when you're looking ahead strategically, we need to make sure that we have a flexible IT service, and that's what we're doing. So we're not suggesting that we're going to change any physical locations, but we need to make sure that we've got the ability to have clinicians practicing wherever that may be in the future, not necessarily to the current estate, and that's what this particular strategy lets do. Susan, I think it's a great idea to do some vignettes about how it's going to be different for patients. So we'll take that away and we'll have a think about how we do that best. Let me just make sure I've got them all. Digital exclusion, I suppose that there is a concern about digital exclusion. We did see some of that, didn't we, through COVID? I suppose what I would say is this is around the technology to make sure that clinicians, where it is right to do so, have the ability to see patients in a variety of different settings. The choice of that setting will always be with the clinician, really. If a patient has to be seen face to face, then they will do so. But equally, if it's appropriate that they could be seen via a video conferencing or a telephone, then again, it's right to do so. And I suppose the IDT strategy is to make sure we have all of that ability, which is what we're trying to do. So I'm not sure, I think I picked up all of those areas. I'm sorry about the noise in the background. I should just acknowledge that. So I think that's what it is. Naz, I didn't quite understand your comment around the COVID consequences over the last 12 months, but more than happy to chat outside about that or to have a more of a conversation now if that's helpful.
Thank you very much, Karen. Any other questions? I think just, clearly a huge amount of appreciation for the work that's gone on. We do have to formally approve this, and I'm sensing from what people have said that we're going to be happy to do that. So shall I just check that as a board we're happy to approve the GPIT strategy? That's a yes. Good. So that is approved. Excellent. Well done, everyone. Well done, particularly, say again, Sam and your team for the work you've done on that. So thank you.
And thank you to everybody who helped, Agnella and Patrick. That was really kind of you to say that, but it's a joint strategy, and you and all the chairs and all of the colleagues who helped during a really difficult, challenging time to give time to put this together. So I'm very grateful to everybody. Just wanted to make that note.
Thank you. Okay, let's just move on then to the H2 operating plan, which is the second half of the year operating plan. For those not familiar with the H2 terminology, Jonathan, you're going to talk to us.
Yes, thanks, Andrew. As you say, this relates to the second half of 21-22, of which most of us will realise we're well into that, as that began on the 1st of October. The guidance to support this only emerged sort of nationally on the 30th of September, so we're busy planning for a period we're already in, I think is worth acknowledging at the start. The good news is that the planning process was very similar in format to that we followed for the first 6 months of this year, and it was focused on 6 areas that are set out in the paper. But just to remind people of those, staff health and well-being, where we are on COVID vaccinations and support for people who've had COVID, restoration of elective and cancer care, and also mental health services, primary care capacity and addressing health inequalities, the urgent emergency care pathway, including community and hospital elements, and working collaboratively across the system to deliver. So those are the 6 priority areas we focused on. The pack talks through the timeline in relation to this, both nationally and our local processes. We made a first submission around elective recovery and winter planning, which is the next item on the agenda, but we made those submissions in mid-October. We're also required through this process to make submissions that relate to the elective recovery fund, the fund that's available to support us maximising our elective activity, and also the target investment fund, which is largely around capital to support also delivering more elective activity. We've had a regional feedback on our first submission over the last week, which is largely supportive of what we've done, but of course there's said where we could further progress over the coming period. And what we're now doing is collating our final plans across activity, performance, money and workforce. We're triangulating those internally in the CCG and also with colleagues in trusts. So we had the first meeting, as Matthew knows, yesterday with Croydon, but working to triangulate with HR directors, chief operating officers and chief financial officers in trusts, the submission, so that we're as aligned as we possibly can be prior to making a final submission in mid-November, so roughly in 2 weeks' time. So that's the process we're in. The paper sets out a lot more of the detail on that, and probably pause there and say happy to take any questions. Other than probably perhaps to note, of course, it won't be long before we're being asked to think about 22-23, and I'm hoping we get to a planning round that allows us to plan for over a longer window of time, and with a bit more thought and a strategic alignment to our longer term plans rather than planning over very short time periods as we have been over recent years, given the ever-changing nature of COVID and the pressures that's placed on the NHS. But that's perhaps a personal wish, Andrew, at the end.
I'm not sure I can fix that for you, Jonathan, but what I would say is, well done, because you've had to do a huge amount of work in a very short amount of time. And I think that the summary pack is really helpful in simplifying it for us to digest, but I know that it's a really complex process, so really well done to everyone who's been involved in that. I'm up to questions and comments. In fact, it's such a comprehensive pack, Jonathan, there's no questions.
We'll take that as a compliment, Chair, in the absence of anything else.
Apart from David.
Well, I thought someone should ask a question, given how important this is. But and as far as the plan and the process goes, I think it's fine, Jonathan. I mean, it's really comprehensive, and I think and certainly the little graphic that's in there describing how comprehensive the process is really good. So well done for doing that. I guess. I was particularly looking at slide, I think it's 45, which talks around what those key targets are. And of course, what we haven't got in here are any of the numbers. So, and I know that will come in, when the numbers have been submitted. But what I couldn't get from here is a sense of, so how big is the challenge that we are facing in H2? I've got a similar question when we get onto the winter plan more specifically, but on this, so for example, it talks about eliminating patients waiting over 104 plus weeks. Well, how many people are we actually talking about? And I think it would just be helpful to see those numbers when they're available, Jonathan.
Okay, can I come back on that? Because some of us are living and breathing those numbers, as you won't be surprised to hear. So I could probably, on that slide 45, give you a sort of a reasonable take on what we're saying at this point in time. So on long waiters, I think we have about 15 at this point in time, and the plan is to eliminate them and get them down to 0 by the end of November. That's our internal intention. The national expectation is by the end of March. On 52-week waiters, we have the lowest number in London, as colleagues will know from the performance report, and we plan to make further inroads into that through the winter, acknowledging that that's getting tougher to do through the winter period, but nonetheless we're expecting to see a further reduction over the period. On 62 wait, we have over 380 patients waiting over 62 days. The target we've been set nationally is 419. There are some real challenges maintaining that through the winter, but that gives you some idea of where we are on that. The issue on the bullet about UEC and COVID pressures, I think we're probably better covering under the winter item, and then sufficient workforce to maintain staff health and well-being, of course, incredibly challenging at this point in time, as everyone is well aware. But part of the reason we're talking about the triangulation process in the way I described is to make sure we're as aligned as we can be across workforce, money, and what we're trying to collectively deliver at this time. So hopefully I've done justice to a bit of the detail you were seeking there, David.
Thank you. And in the course of that, Jonathan, you've answered Bruno's question as well. So well done. Right. Are we happy to note that? And let's to the winter plan, which I think is, I mean, clearly that's another huge piece of work, and I know there's going to be a fair few questions on that. So Jonathan, do you want to go straight on to that?
Yes, very happy to move on to that, which, as I say, is also part of the overall planning piece that we've been doing as part of H2 preparation. So this document, I think, is very important for us all to have some collective confidence that we will get through the winter in the best possible place that we can. There are really two streams to this piece of work. One is around some modelling work we have done based on London and national assumptions, which really clearly articulates the scale of the pressures we're likely to face and are already facing, actually, on all parts of the system, and particularly notes the pressures that we'll see in hospitals in relation to the general and acute bed base through the winter. So this work does call that out, and of course part of the way that we'll be working to mitigate that is thinking about what that means for elective care through the winter. Of course, we'll be trying to maximise what we can do, and this work has shown that we can continue to maintain urgent elective care for the most needy on the basis of clinical need people through this period. But it does say it's going to be a very challenging time, as we're well aware of. As well as that modelling, there is the narrative that's before you that's been shared with a range of audiences over the last few weeks, and has including health and wellbeing board colleagues and chief executives across NHS organisations. And it talks, as well as the acute elements, about all the other components of the pathway that we need to focus on. So very much focused on flow and how we support patients to return to the community as quickly as possible, be that from the front door, so same day emergency care pathways that allow people to return home rapidly, or be that with the support that people need after being in hospital. It talks about our mental health plans, a really important element of what we need to support this winter for both children and adults. It touches on our vaccination plans. It talks about our communication plans. It highlights the risks that we face, most notably the one around staffing and workforce. It talks about the impact of the guidance relating to social distancing, etc., and avoiding overcrowding of urgent care spaces and what that means for pathways this winter. It reflects on other pressures other than COVID. So, for example, some of the respiratory illnesses that children have had through this period, and also the impacts of flu. And it also says how we're all going to bind this up in a coordinated way across the system through a South West London operations room. So that's what's in the slides. There's a great deal of detail in this pack, which I'm happy to walk through if people want me to walk through. I think it is worth noting, given a letter we received from NHS England last week, that we every day are very closely looking at our ambulance handover delays and the pressures that we have there. Normally South West London performs well in this area, but it has been more of a challenge in recent weeks, and we will do all we can to support paramedics and others to get ambulances back on the road, and to have patients admitted in a timely way as possible to hospital. So I could go through section by section, and I'm happy to, if you want me to, Andrew, but equally I'm happy to pause there and just seek people's comments and questions on particular aspects of what I think is a really important document, because this is how I think we need to hold ourselves collectively together through the winter to do the best to ensure that patients have safe, accessible care over the coming months.
So let's not go through page by page, because I'm assuming people have read it, which I know I've been through it. So probably let's just focus in on those areas where people have got questions, and then you can pull out some of the detail for us on those areas. So let me open it up to questions. Liz, first.
Thanks. I've got a couple of questions in relation to adults and one in relation to children. The two questions in relation to adults, and we can absolutely see what the rationale is for this whole programme and how important it is on page 59 of 141. It refers to the the bed bureau being made a 7-day operation so that complex discharges can take place at the weekend. As health watchers, could we ask whether there is confidence that the community services and social care are also in place at the weekend for those complex discharges? The second question is on page 60 of 141, which refers to exploration of additional voluntary and third sector hybrid support, and we wondered what the timescale is on that, what is envisaged by hybrid support, and also has the capacity of the voluntary sector to undertake this been assessed? So that's the second question. And the third is around children's care, and this is page 62 of 141, and it refers to the internet-based health advisor service called Healthier Together. And we wondered what discussion has there been with providers of the health visiting service across South West London in order that work can be coordinated with the standard health visiting service. Thanks.
Thank you, Liz. Jonathan, you look like you're making a note of those.
Well, I am given the number of hands up. I was preempting.
Right. So let's take the other ones, and I'll come back to you, and you can hear or other people to help depending on what the topic is. So, Pippa, shall I bring you in next?
Thanks, Andrew, and thank you, Jonathan and the team. The really good plan, hugely complex, and there's a lot in there. So I've got a comment and then a couple of questions, one of which builds on Liz's. It was really good at the beginning to see the behaviour change campaigns, so that was good to see. You highlighted in your update to us that workforce was one of the biggest risks. We could see how operationally in some of the boroughs on a day-to-day level those are being considered and mitigated, but it's a question for us as the governing body. I wonder if we should also look at this strategically. We've signed off a workforce strategy and whether at some point we should have an update on how that's progressing at a strategic level. So that's the first question. And then the second question builds on Liz's. It's around the exit flow plans. Liz has picked up a lot of the voluntary sector issues, but I also wondered whether there are any risks with any of our local authority partners around some of those exit flows.
Thank you, Pippa. So let me come to one of our local authority partners. Dagmar, you're next.
Yeah, thanks. So I wanted to pick up a public health issue rather than social care, although I absolutely agree. I think it's a great plan. I'm going to share it with my across in my council with my social care colleagues. It is a big document, but it is very helpful to see it in the round. So I don't feel quite the right person to talk about the social care. I wanted to pick up, Jonathan, a pretty specific issue around the potential of flu going wild over the winter. And we've got a letter from Wynne Dinwaka. It went to primary care, I think, as well, to be prepared to set up the antiviral distribution stuff in case flu will get rampant. Now, that's a bit around, I think, preparedness generally. So my question was, I couldn't see it in the plan, and it's not a criticism because, you know, there are only so many things you can put in. But would that be operated through your operations room? Because the community pharmacists obviously are a really important partner together with primary care if we should find ourselves in that situation. I mean, hopefully we're pushing the flu vaccination plus a bit of social distancing thing going on that we can keep flu at bay. But in terms of preparedness, it is an important bit to consider.
Yeah, really good point, Dagmar. Thank you. That's really helpful. David.
Yes, Jonathan, just to raise something ask a question that you may not be able to answer, but I'm going to ask it anyway. And that is that it's really about how much headroom is there within the system, and what are the tolerances that we're operating through this. Now, I know that will depend on how much activity there is and the whole lot of issues around if, buts and maybe, but I don't know whether you can give us a sense of, other than the system's busy, it's very tight. Is there any measure that we can say, well, look, we know that, we're okay on emergency activity at this level, but if it goes above that tolerance level, then there's a problem or not? I don't know whether you can give any sort of sense of, let's say, how tight the system really is. Thank you.
Thanks, David. Agnello?
Yeah, I just wanted to highlight another key issue, which I don't think the documentation brings out. It's not just the numbers of staff, which we've got a shortage of, but it's also, we've got tired staff right across the urgent emergency care space, whether it's in primary care, secondary care, tertiary care, and I think the need for clinical leadership, the need for leadership from governing bodies and trust boards to support their front line, because a lot of people are running on empty at the moment, and it's just not going to be numbers of people. There's a shortage of staff already. It's about how do we support frontline staff wherever they may be, to be able to carry on and to do the best that they can do. And we can lay out the plans as much as we can, but really it's that leadership that is needed to support the front line as well, and we shouldn't forget that.
Thank you, Agnello. And Vasa.
Thanks. To build further on Angelo's point there, it's not only the staff who are tired and fatigued, our citizens, our patients are also tired and fatigued and worried about their health and well-being. And I think we need leadership across the board, clinical leadership, managerial leadership, and civic leadership, so that we can all work together, especially over the next 4 or 5 months, to get over this the cloud of winter and then build in the spring a New England.
Thank you, Vasa. So, Jonathan, you have had a huge range of different reflections and questions and comments, and there's one more coming from Matthew.
Well, I was trying to time it. I've obviously done it badly, Andrew, so that I could come in after Jonathan just to give any further reflections, so that it's not poor Jonathan doing all of it, because he and I work hand in hand on this, both from a South West London perspective, and obviously I've got a take on it from a place perspective. So I just wanted to come in afterwards. So apologies, I've started.
It's a hand offering support. So I will come to Jonathan. I mean, I know the winter plan is also involved a range of different directorates, hasn't it? It's been quite a concerted system effort in pulling this together. So I'm sure you're going to want to bring other people in for some of the responses, but I'll come to you, Jonathan. You can coordinate the collective response.
Okay, well, I'm going to give an overview, if I may, of trying to answer some of those points, and then just to give people a heads up, it would be great if Karen could come up for feedback on some of the workforce bits. Helpful for Tonya to also probably talk about some of the discharge elements, and Charlotte might want to talk about some of the comms components of this all too. But if I work my way through the questions as best as I can answer them, and then hopefully colleagues can supplement them, and Matthew can sort of wrap up, if that's okay, Andrew. So to the sort of challenge from both Vasa and Agnello, so I think we have to acknowledge, don't we, that many members of staff have spent 18 months in PPE, for example, now, to give you an example of the scale of the challenge. So completely understand the point about a tired workforce and also significant gaps in workforce. And there's a real leadership role for us across the system in supporting and energising through this difficult time. So I think that's a really important point, and something through the conversations I referred to actually under the previous planning item we've been trying to do to ensure that we're not just focusing on activity and performance on money, but very much workforces are right at the epicenter of what we need to do and how we plan for this winter. That feels like a timely point to bring Karen in. So I don't know whether, Karen, did you want to talk about a bit more about the workforce piece?
I think there's two things. I mean, there is the whole health and well-being agenda, isn't there? And Matthew can talk about this from his own trust, but I know that in each of the organisations there is a huge amount of work and an extension to health and well-being office that's been put in place over the last, certainly over the last year. We're also investing in health and wellbeing hubs from a system perspective and extending the range of services and the number of staff that they will see. So there's a huge amount, I think, going on to try and support staff and their health and wellbeing over the months ahead. I know actually over the last few months and over the last year. I think in terms of workforce numbers, we're working with HR directors at the moment to try and understand their staffing levels over winter. There are only so many staff that you can get from so many areas, so we're asking them about the numbers of their permanent staff, how they may use bank and agency staff over the next few months, how we may redeploy staff should we need them, as we did in COVID, and how we may want to think about using different staff, our use of volunteers, across the system should we need to, as well as which are the new recruits and new roles that we're expecting to come online over the coming weeks and months. Then we will discuss with them whether there are any workforce gaps and therefore how can we fill those gaps. When we had our response to COVID and we worked with across organisations to support each other with workforce, we moved staff from community trusts into hospitals. We had primary care staff going into hospitals, etc. So when we understand the scale of the gap, we can then work out with HR directors how we may mitigate that gap. But there are huge amounts of conversations going on and huge amounts of work in organisations, in practices and in hospitals and in other organisations to try and support staff through what has been a really tricky and difficult emotional and physical time over the last few months, but equally in the time ahead. So there's a huge amount of work that continues. And as Jonathan alluded to earlier, we are also then going to meet with the directors of finance, operations and HR in each of the organisations to see with them to make sure that that planning is triangulated around to make sure that we've got the right staff going forward.
Shall I keep going, Andrew? Is that okay? So sort of moving back up the list, and there was, I think, David's question about how busy is the system. I think that was the thrust of the question. And of course, we do have a lot of data that tells us how busy it is. So you can see, for example, core volumes to 111 up 20 or 30% over what we were expecting them to be. The question, I think, is or could be around the sort of bed pressures that we're expecting to see through this winter period. And this plan suggests that at the peak of those pressures that we could be around 100 or so beds short of what we would want available to us to deliver urgent emergency care. So that's where there will be a potential knock-on impact into elective care. We're doing our best through the elective equipment and through Queen Mary's Ramsden, as we touched on earlier, to keep as many pathways open, but that's where it could potentially impact on some elective care pathways. Now that might sound like a lot of beds, but it is about 5% of the overall general and acute bed base in South West London, to give you some idea of scale. But it represents a very real challenge, as many of our trusts are already experiencing, of coming in every morning to a number of patients who need to be admitted, and we have not yet been able to find them a bed. So it's very challenging, very hot out there. Hopefully that gives you some idea of the scale of the challenge that we might be facing at the peak of where we're at. But I would also want to reassure people that we will continue to provide urgent emergency care services to people who need them in a timely way, and we will continue to keep elective care pathways open for those who are in the highest categories, so priority 1 and priority 2 elective care pathways. And the evidence to support this is also there from what we did through the second wave of the pandemic, where we managed to sustain those services through a very difficult period, nearly a year now. So hopefully that's a little bit of heads up and feeling about system pressure. David, have I done justice to your question?
Can I come back, Andrew? Yeah, I think you have. Thank you, Jonathan. I guess it's really where is the? It may well be more a question that comes into, you know, then how are we monitoring where we're at on some of this? And I think, you know, obviously, because if you break down each service, you could say, you know, there are different tolerance levels that we're operating on week, because we're not looking at a single system, we're looking at a whole range of services that come together to create that system. So I guess, you know, it's having just a bit more detail on where are the tolerance levels and where is the headroom and where do we think the real pinch points are going to be. So I don't necessarily looking for any more, and you know, anything else from you at this stage, but maybe that just needs to be picked up separately, which I'm sure you're doing anyway.
Yeah, thanks, David. Probably more appropriate to deal with some of the detail outside of here around that, but I think I would want to assure board members that we are very clear about what some of those tolerances are, and we're very clear what we are measuring and monitoring across, you know, all areas to give us some indication of pressure. And what might be helpful to share is the report that we pulled together for the recovery board, which also pulls out some of these metrics in a bit more detail. So that might be a further thing that we could share that would give people confidence that we have this information. To add to that, the Surge team have an awful lot of information to collect every single day, and also the Acute Provider Collaborative have a significant amount of information they collect every single day, and they share that with us around the system. So we are well cited on the pressures, I think, and we're doing our utmost to manage them, but very happy to have a bit more detail on each service and the thresholds, David, if that would be helpful outside of here. So if I work my way back up, and I think next was Dagmar and flu. So I wouldn't aim to be an expert on this topic, but in terms of our flu preparedness plans, you mentioned Vin, the regional medical director, Dagmar. Then we are required to have robust flu preparedness plans, and they're part of what we would be managing through our operations room and through our emergency preparedness response arrangements. I think we're all aware that given flu seasons have been relatively small in number because of social distancing over the last year or so, there's a significant risk this year. So thank you for making the point, and I think we should be picking that up through the operations room arrangement. So that's probably what I want to say on that. So then there was Pippa's questions, a question about the sort of link to the workforce strategy, which I think Karen's sort of already touched on, but I think it's a timely reminder. So Karen may want to say a little bit more on that in terms of, because that's about a long-term plan to address the fundamental challenges we face as a system, isn't it? And in terms of exit flow and your other point, so we are seeing an increasing number of patients who have been in hospital for more than 7 days and in more than 21 days. That is and that's been increasing for a number of months. that is part of the issues that we're facing at the moment. And I know Tonya and the team around discharge are doing a massive amount of work. For example, there's the intention to have more than 150 community beds in place through the winter to support us with a range of facilities, from people with COVID through neuro rehab, through general community response type beds. So, Tonya, if you're with us, do you want to say anything more on the sort of discharge piece? Because that also picks up some of the questions we had from Liz too.
Yes, thanks, Jonathan. Yeah, we have been working on our South West London discharge programme in the last couple of months with providers in health and care. So the question from Liz was, is community provision and social care provision available 7 days a week? It is, and it's been funded to do that. So we've been able to secure both funding for community services and local authority to work 7 days a week. I think there is a conversation about where that is optimal and actually where we focus that. So we're having those conversations still, but absolutely they are funded to do that. And we also recognise in local systems the benefit and the role that voluntary sector organisations play in discharge. And again, it's around making sure that they're appropriately resourced to be able to provide the support. So a hybrid model would be, I was looking at a scheme from Croydon Local Authority this morning around actually voluntary sector work at the front door, ED with staff to signpost people away from ED in crisis. So actually they're attending an ED in crisis, but actually that's probably not the right place, and we can support them to be in the right place. So a hybrid model would be voluntary sector working with staff in services to augment and provide a holistic service and prevent admission and attendance. That would be one example. Another example in Kingston would be the Stay Well, who support a discharge by doing the key safes before discharge. So it's that kind of work that voluntary sectors are doing to support discharge, and they are being also funded to provide extra capacity. So that is a funded resource. So it is a big programme. It includes discharge. We also have our virtual ward, which is really starting to bed in South West London, that can support people in the community with remote monitoring, mostly respiratory, but also cardiac and diabetes. We also have our enhanced health and care home programme, and as Jonathan says, we have our discharge bed bureau that helps flex capacity in the community across all 6 systems when required. So quite a big programme, and working in collaboration with all partners.
Thanks very much, Tonya, for helping with that. And then I think the other part question from you, Liz, was about the sort of Healthier Together programme, which is an initiative I think set up originally in Croydon. It's a sort of internet-based service that's designed to help families choose the most appropriate pathway and access to services, and that's something that Matthew and I have been working through the UEC board to support rolling out across South West London. On specific the health, so go and check how that's linking to health visitors in each patch, but that's the intention of the tool, to help support people, to families to make the most appropriate decision about how they access healthcare, because we're aware that that's an issue that's grown through the pandemic, and Croydon seem to have done some good work that we might be able to learn from and replicate more widely. And I don't know, Charlotte, I don't know if there's anything you wanted to add from a comms point of view, and then perhaps we go back to Matthew to wrap up and just check we've covered all bases.
Yeah, so quick. So I think, Pippa, you are right. You know, we are doing a broad communications but also engagement campaign for winter, with great support actually, Dagmar, from local authority colleagues, as well as obviously NHS Trust, Health Watch and voluntary sector, really about sort of prevention but also demand management. And in the slide deck, sort of you mentioned you've got a pharmacy piece, one first piece, what a flu COVID booster. I think, as this is a meeting in public, local people can help us, and it's about talking to local people around how actually pharmacists are clinical experts and can really help people as a first point of call, and for 111 as well. So it's sort of getting that message out sort of deep into our communities. And I think, Dagmar, when you're talking about flu, again, you're correct, because we had lower incidence of flu last year, didn't we? But we have a combined campaign with flu and booster around Boost Your Immunity this winter, which hopefully you've seen. And I think probably most of the members of the governing body will be old enough to remember the Ready Break commercial. And it kind of has a nice gold line around, people in the pictures. So hopefully that's an engaging way to get out to our communities and talk about how important flu is, as well as COVID-19 boosters. But the insight work that we do to make sure we get our campaigns correct, are telling us that local people do have a bit of complacency around the flu vaccine this year, obviously because people are very distracted with the booster, and we had low incidence last year. So we're keeping on working with our communities to talk about how important it is, and we'll keep you updated on that.
Thank you, Charlotte. So should we go to Matthew?
Thanks, Andrew, and I have the lucky, if not sometimes an enviable task of supporting Jonathan on urgent emergency care for South West London, as well as my local responsibilities too. And I think the comments that have been made in response to the questions we've got covered would Andrew alone, just to sort of add my reflections, but ostensibly I'd support entirely what's being said by colleagues. I'd say at the moment, in terms of pressure, that I've said this to other places, but it doesn't harm to tell it again. There is real challenge across the whole piece, and there is something very much in the DNA of South West London, I think, to work as a collective on these things. And I think that's right, and that's both in terms of the solutions, but also acknowledging the challenges. And I've said it in other fora, there's not a competition for which part of the system is having the most challenging time here. I think evidence would suggest that primary care, community services, acute sector, social care in each of the boroughs and across South West London are all at points having exceptionally challenging levels of activity, demand, and challenges around workforce, etc. So, we're a bit all in together. Answer the question, what is that scale of pressure? I mean, it's not a formal metric, but if you ask me today, after 30 years of working in the health service, what it feels like we're in late December, mid-January, not the start of November. Now that's not a metric that's easily sort of calculated or monitored, but that the levels of activity and the challenge that people are facing feels a scale up from what you would imagine at this point in the year, and that's on the back of obviously quite a challenging 18 months for all the reasons that we know, and so that does impact on how staff themselves right across all of our systems will be feeling, because it isn't the middle of January, it's the start of November, and there's the whole of that period yet to come. That's why our plans, I think, are very comprehensive, and we've worked well on them. But it would be, I think, remiss of us to this body not to say that there are, elements of those plans that are still very much work in progress. Not everything is absolutely fixed to a point at which we could say here today, everything's going to be fine. It's all going to work smoothly, and there's going to be no issues of extended waits for patients and the impact that has on staff. I think that would be the wrong message to give at this moment. What we're not saying is that we've therefore sort of thrown our hands up and said, well, there's nothing we can do. You've heard loads of schemes about what we can do and will do, both as individual places and as a collective across South West London, and more of that to come, and we will work, I think, positively and well in that regard. but there is a scale of challenge here that requires us to be straight with you guys and focused on all that we can do to address it. So I think that's what I would say on the pressures part. Then in terms of the responses to that, I think we have a whole load of schemes in play and more to come. There is some really interesting innovations in all patches. Croydon obviously has its bits, but so do the others as well. And part of our job is to share those and make sure we're getting the good learning from across each of us, and we'll do that. And crucially, we do need to make sure that the support for our staff is there, and that the health and well-being, both physically and mentally, is as significant as we can make it, because we are going back to a workforce that has been through a very tough period. It's going to be another period of similar challenge. We have to keep our patients safe. We have to keep supporting our staff, and if we do both those things, as I know we will endeavour to do, then we'll be in the best possible position for the winter. So that's probably what I'd say as a sort of round-up conclusion, Andrew, rather than repeating the points that have already been made.
Thanks, Matthew. Really good way to wrap up, actually. Okay, so I think we've given that a thorough testing the plan, really helpful discussion. So let's note that. Jonathan, it's still you, I'm afraid. We're going to go on to emergency preparedness, resilience and response assurance. Bit of a mouthful.
Thank you.
EPRR, I know what you call that.
You'll be pleased to hear this is the last of the trio of items for me, Andrew. So the final one, obviously linked to what we've just been talking about strongly as well, which is probably why it's at this point on the agenda. And just to say, I entirely echo Matthew's points about it feeling like the depths of winter already, and the metrics I think back that up in terms of where we are. So just to bring this report, so this is a sort of annual report to the governing body on our emergency preparedness. I think, to be blunt, it's often about testing the assurance that we've done, that put the right things in place. We've been living and breathing it, really, haven't we, for the last 18 months in action. So the report talks about the COVID pressures and how we've responded to those in terms of our emergency response. It talks about some of the practical experiences we've had. So, for example, a year ago, some of the oxygen supply issues that we had in South West London and how we coordinated that through the PRR arrangements. And in addition, the two other sort of areas that have been the main focus through this period on EPRR have been the EU exit transition period ending at the end of last December, and there was intensive daily reporting and monitoring of that at that point in the time to ensure, feels some time ago now, doesn't it, but we all had access to the services and medications and all the other things that we needed into January of this year. And then more recently, the challenges we've had around blood vials through the summer period, where South West London was among the early parts of the country to recognise there was an issue, and we've been holding intensive arrangements to monitor through that challenge, which has significantly eased from where it was in the worst points in periods, but something we're continuing to maintain a close eye on. So there's sort of 4 practical examples of how we've been using the emergency preparedness piece in action. It's also worth, I think, saying we sort of strengthened arrangements through the operations room as the paper sets out and bringing the EPR elements into that. And the on-call arrangements we've also strengthened through the period, moving away from the commissioning unit providing those services to something that's led by band 9s and very senior managers across South West London, adding additional resilience to what we've put in place. The document also talks about the self-assessment we've made that we're required to assure NHS England, and NHS England then review that plan. We expect the outcome of that later in November. but all the signs talking to the team yesterday about this are that we will receive full compliance, as we have done in previous years, from the regulator. So that's probably all I wanted to say. As I say, it's a sort of fairly standard report that the governing body should receive on an annual basis, but we've been using it very much in action this year, Andrew.
Yeah, so a standard report in terms of it's a standard thing to report on, but very far from a standard content to the report. And I think you've done, an amazing job, and everyone in the CCG has been involved in the emergency response in dealing with really unprecedented challenges. So, and obviously the report covers that to some extent. So really well done, I would say. Any questions or comments on the report? I mean, I know, Jonathan, this is for assurance really for NHSC, and you're going to be going through the process around that. So we'll take the noting, but really helpful to see. I can't see any hands, so I will just take that as noted. I think we've had a big discussion around preparing for winter, and this is just, I guess, a really helpful report to remind us what we've been through in the last year. Okay, shall we go on then to the updates and reports from the various committees and directorates? So we're going to start with finance. So James, over to you for the finance report.
Sorry, I started talking and I was on mute. Apologies. So month 6, clearly the end of H1. Now we work in half years as we do at the moment. So the CCG's delivered its financial balance for H1. As people are aware, we've had a pressure on CHC. We're starting to see in certain areas a bit of levelling off on that, and we've now set up the system governance process to manage that, which Gloria chairs and runs. So we've got work in train to try and bring that down in the second half of the year, and particularly as we go into next year. But we'll report on that as we go through. The pressures on that have been mitigated by underspends in other areas, in programme areas, which a lot of which is because we haven't done things because of the COVID response, etc. We're now, as Jonathan outlined, all the H2 planning. We're still not quite in the stage where we do finance and activity planning directly together. So that triangulation process that was talked about earlier is quite critical. From a CCG point of view, we forecast some increase on some continuing pressures on the CAC. We've got enough money in our programme to offset that. So we're predicting at the moment an H2 plan balance for the CCG, or the elements that still remain with the CCG. For the wider system, there are a lot of pressures. You've heard there quite clearly all the winter emergency pressures and all the pressures to keep elective recovery going. We're still working through that for H2. There is a gap as a system overall, but we've got another couple of weeks to try and resolve that, which is what we're working on. I think the key message to highlight is that, and this might cheer Jonathan up, so some of the finance stuff I saw did give us a full year picture for next year. So hopefully we will start moving away from 6-month planning rounds to something that's more programmed. The financial regime is likely to roll forward in the way that it is, at least for the first year of the ICS, in terms of the amendments we've seen operate over the last year. I think the key message is that I can't remember who said it now, but somebody said wonderful to get through winter and new pastures in the spring. Finance is going to be very much the same thing around that, because once we've got through H2, we will start to see some of the COVID reduction, some of the COVID money that we've been given to get through the pandemic come out, and some of the other financial supports will start to come out. So we will need to look as a system how we respond to that, to make sure that we've got the finances lined up with the future service strategy. And that will be a challenge, because we will need to do some of that work over the winter when everybody's trying to do everything else that you've heard very eloquently eloquently explained. So I don't underestimate the size of that challenge, but equally, if we don't tackle some of that early, then we won't be seeing those new pastures that were highlighted earlier. So that work will start. Well, it started already, so we'll be working through that, and as guidance comes and we get more clarity on the numbers, we'll be able to clarify what that looks like. So I'll stop there, Andrew, and let anybody ask any questions on that.
Thanks, James. Should we get straight on to David and just hear from you, David, as Chair of Finance Committee? We've got
a question from Bruno, I think. Sorry, Andrew.
Just a request for a bit of an expansion on what the process going forward would be in terms of trying to manage that currently 10% overrun in continuing healthcare. That wouldn't have any kind of implications in terms of the CCG actually meeting its responsibilities to patients, because I think that just given blankly, that might be the kind of thing that would concern patients that might impact.
Yeah, so as I say, we've got there are two aspects really. There's one, just we've got the process that Gloria's now chairing to work through how we get control of that, and there's a lot of disruption in this. That's partly why we're seeing this sort of flattening out, I think, because it's a little bit different in all the different boroughs as well, around coming out of COVID and what impact particularly last year that had. So we're working through that, and we'll make sure that's under control. There's then a bigger piece of work as we move forward into the ICS about how we manage the overall sort of discharge process, which we'll be working with local authorities on. So, but clearly, Bruno, we'll have to follow all due process. So please be assured that it won't be a blanket sort of process to that. It will be tuned and it will be clinically led. I think I don't know whether Sarah had her hand up and then put it down there, but it will be clinically led, which is why Gloria's chairing it and not me. Sarah, did you want to add something to that?
Yeah, just to assure people that we will meet our statutory requirement around CHC. It is a clinically led process. It's a national assessment process, and we would absolutely be committed to ensuring that happens. We have to deal with making sure the costs, maybe when we do placements, are the right costs, that kind of thing. But so we'll look at where we can be more efficient, not about reducing packages or doing anything that's clinically wrong for individuals. So just to assure you on that.
Thanks, Sarah. Then, shall I see you as Finance Chair, and you can give us a quick overview of what your discussions have been at Finance Committee, and then I can take further questions on the money as a whole.
Yeah, thank you, Andrew. I mean, just to say what I may have said this before, but in terms of what the Finance Committee, the committee is doing, I mean, I think the committee is there to provide assurance to the board around all of the financial stuff that James has gone through, and I guess there's a sense, I'm reflecting back on previous boards which would have spent a load of time just talking about the detail of the numbers, and we don't do that as a board. I think that's mainly because the board can be assured that level of scrutiny we are doing appropriately through the Finance Committee. So we most meetings are running for an hour and a half to 2 hours. We're going through that level of detail with James and his team, particularly in terms of the position for the CCG and then the wider financial position of the system. So we're doing that level of scrutiny. It's not just a nod through on the papers that James presents to us. We're doing that level of challenge, and that's happening. I'm not going to repeat what James has said. I mean, you've got the report. If board members want to look at anything rather than all the detail, then it's the scorecard, which is all showing as green. I would just reiterate the point that relates to the first half of the year, and so we've been able to manage the CCG position for the first half of the year. There are some risks, as James has said, going forward, and we've talked about where we are on the community health, on the continuing healthcare as being the key one. So that is it. And just to note, then we're continuing to look at single tender waivers where we've approved a number and one or two other things that are going through the finance committee. But I'm happy on as the finance chair to say that we are doing that level of assurance, and the board can be assured that that the CCG is on top of its finances. But happy to take any questions to me or other members of the finance committee if they want to contribute. I'm sure they will do. So thank you, Andrew.
Thank you both. So any further questions on finance? No? And we've got Vasa and Naz on, who are also members of the finance committee, haven't we? Good. Okay, so we're happy with that. That's for noting. So should we go straight on then to performance report? Jonathan, back to you.
Yes, thank you, Andrew. So I think we spent quite a lot of time talking about some of the urgent emergency pressures a little earlier on this agenda. So I wasn't going to spend any more time talking about those, though people may want to ask more questions on the detail of them. But you can see pressures on things like 4-hour performance. Positively, I think we're doing really well as a system, and reiterate my thanks to the work that trusts are doing to deliver access to elective care at this time, be that inpatients, outpatients or diagnostic services, where we are continuing to do routinely the best in London at recovery in those areas. Of course, we've still got somewhere to go to meet the requirements set out in the NHS Constitution, but we're often a long way ahead of colleagues and peers and continuing to make progress. In August, which this report relates to, we did see a bit of a flattening off some of that, which you'd expect due to some of the workforce issues, and we were seeing the end of the sort of pandemics piece then, and also staff annual leave. But we in September and October we've seen the upswing we'd expect us to see, recovery of business as usual activity on electives, which is really good in the context of the urgent emergency care pressures we've spent quite a lot of time talking about. So also through this period, cancer performance has remained strong, and we remain the best performing part of London on cancer services. I would note as we enter this period, we're seeing more challenge on that in most recent data on things like 62-day from referral to definitive treatment. So that's something that we'll be watching carefully and working with the Royal Marsden Partners, our Cancer Alliance, on. Mental health performance remains really strong. You can see that in the dementia diagnosis, IAPT access and recovery figures. The challenges we've seen on laboratory West CCG and the physical health continue to apply to mental health patients, though we continue to open and try to address those issues. So, for example, mental health assessment unit opening at Croydon this autumn is an example of how we continue to try and address those weights and issues. Probably also worth noting, there is an ongoing challenge on the physical health checks for people with serious mental illness, where we're off where we need to be for our Q2 trajectory. Some of that is no doubt linked to the pressures on primary care, both the direct pressures on primary care and indirectly things like, the blood bile issue I mentioned earlier may well be having an impact on some of those things too. And of course, there's also a strong correlation with the quality and outcomes framework and how that ratcheted up through the course of the year two. But I think there is probably learning from the boroughs that do best at this, where they have dedicated resources. So, for example, Wandsworth and the biggest improvers, which was Croydon, where there's been more resource put into this in terms of dedicated people to support. So there's, I think, probably some learning across the system on that. But overall, we've touched on the urgent emergency pressures. they're the big area of performance challenge at this point, and the system, I think, is doing a good job of maintaining access and timely access to patients across so many areas, given the competing challenges that we talked about and the workforce challenges that we've drawn attention to on numerous occasions through the course of this meeting. So I'll probably stop there and go to any questions people have, Andrew.
Well, shall I just go to Pippa first, because Pippa, it's probably just helpful to get your perspective from QPOC, and then we can again just talk about performance and quality issues in the round. I know at QPOC you saw the month 4 performance report, didn't you?
We did, thanks Andrew. So yes, I do have a couple of questions for Jonathan on this more recent report, but I'm happy to come to those afterwards. So I'll just very briefly take you through the chair's report for our October meeting. I think it is largely self-explanatory, so I'm not going to go through the whole meeting, but happy to pick up any questions. Things I would like to highlight. So we had a paper on our learning disability out of area placement, and the assurance on how we are commissioning placements for people out of the South West London area and what that looks like. The process is being strengthened, and the area that we particularly tested was how we are using patient and family feedback in informing what that process looks like for the individual concerned. So we got some good assurance around that, but it's an ongoing piece of work. The other things I just wanted to highlight was the quality and patient safety report, so page 2 of my report. We're continuing to work with all of our providers, but the way we work with them has changed and is continuing to change. So we're now part of their internal meetings, and I think that brings us closer to understanding what some of the frontline issues are for staff. And you'll see in there that workforce was a theme that came across QPOC, and as Jonathan says, we've highlighted it here. And you'll see at the end of this that we've asked it to be added to the risk register. We also had an update on our equality work around hypertension and diabetes, and you can see in the report the good work that's going on in that around all the primary care networks. And we noticed that one of the largest challenges was how we overcome barriers to people not engaging with some services. And we heard about a successful pilot that was taking place in one of the health and wellbeing hubs. So, and how that learning is being shared. And finally, we received a couple of reports. So, looked after children, annual reports. There's some really good work going on across South West London. We thanked everybody involved with that, but we aren't achieving all of our initial health assessments, and we'll review health assessments everywhere. So we've asked that we keep a more close oversight of that, and that's going to be added to the quality report. And you can see in there the details of the CQC provider collaborative review of cancer pathways in South West London, which again was good, and the recommendations that have been included. And that was all I wanted to highlight. Thank you.
Thanks, Pippa. And did you want to go into your questions then for Jonathan on month 5 report?
That's helpful. Yes. So it is, as Jonathan says, some really good performance happening across the system in view of the challenges that are going on. I think, Jonathan, you answered my first question in the winter plan, which was around and was impressed with 5% of our population who've got the over 52 weeks, and you highlight in your performance report that challenges are in general surgery, ENT and cardiology. I think you said in the previous paper that there are plans in place to continue to try and work on reducing those. So it'd be good just if you could just reinforce that. To let the governing body know that QPOC have got SMI health checks on our agenda for our next meeting. So we'll get a more detailed update and report in December. And then the final question, Jonathan, was on the London ambulance handovers. they are beginning the 30 and 60-minute breaches in this report. They're beginning to go upwards. And I noticed in the winter plan there were a number of mitigations in there to try and help manage that. And I just wondered what the timing was for some of those mitigations being put in place.
Yeah, good question on LAS. We had a discussion about that clinical leadership group on Tuesday. So Jonathan, shall I come to you?
Yeah, okay. Well, just to start then on that LAS question. So I alluded to the letter we've had from the National Director around this last week, and there are a whole range of actions that we're taking. I guess one that we're exploring in extremis across the system is what we call cohorting, where 1 or 2 paramedic crews stay behind with a patient while another 3 or group of patients, while the other 3 or 4 ambulances who had arrived at the A&E are able to go back on the road and take care of those patients. So we have a model of cohorting that's in place in some of our trusts, but not all our trusts. So we need to think about how possible that is on other sites, recognising it's very challenging from an estate point of view. And we also have Matthew and I were talking about this just earlier this week, what we might call reverse cohorting, where staff in the emergency department are going out to care for people in ambulances to ensure they're getting some care for their admitted time to depart. So those are some of the issues we're doing in extremis, because we have to keep patients safe at this time. It is a conversation a number of us have had with the Chief Exec of the London Ambulance Service over the last few days, just how we could do even more through periods of peak demand, how we might want to think about what's called intelligent conveyancing to make it even more intelligent going forward, about how that operates too. So there's a whole array of actions, and we are being very closely, assiduously monitored on how we're doing around ensuring ambulance crews are back on the road and people can have timely access should they need it. Pippa, so I think that's probably what I want to say on that. So as you say, we'll congest the health checks piece at the Quality and Performance Oversight Committee. So just on the first question, so I think I heard you say it was sort of 5% of people waiting over 52 weeks. I think the number is lower than that. It's about 1% of patients who wait over 52 weeks. So we currently have in this report 1,369 patients who are waiting over 52 weeks on an overall waiting list of 131,000, just to give you some idea of scale. But of course, that's still 1,369 people too many, and we're working very hard to reduce that still further. I think there was a second part to that question, Pippa. Do you mind repeating what the second part of it was?
No, that was it. Thank you. Because you picked up, there were 3 areas that we specifically got issues, which was for general surgery, cardiology and ENT. And I just wanted assurance that, because for those people, as you said, it is going to be having a big issue. So needing confidence that we are going to continue to work really hard to reduce that.
Absolutely, to provide reassurance on that, and it's something that with Sarah and others, the regional director is very carefully monitoring on, particularly patient. I mean, the regional focus is on people who've waited 2 years rather than 1 year actually at the moment, i.e. 104 weeks, and we need to clear those. We've made some real inroads on people who waited 78 weeks, and we're continuing to focus on 52 weeks, and we will continue to do so. But in this pack, you can see we are doing relatively well in comparison with other parts of the capital and outside for that matter. But that doesn't mean we're not closely monitoring them. I know the details of all 15 patients who've waited over 104 weeks. We are very close to the detail on this.
Thank you both. Any other questions for Jonathan or for Pippa on the report from QPOC? Liz.
Thanks. I've got a couple of questions in relation to serious mental illness, and I think one of them might be picked up when it's discussed at QPOC. which is about the physical health checks. I'm just interested to know how the remote monitoring for SMI physical health checks works, but happy for that to be picked up through QPOC and hear about it at another date. And the second one is page 129, which is the metric on 63% of patients started treatment for psychosis within 2 weeks. But we don't have any data for the other 37%. So, if we could have some idea of simply, what the waiting times were like for the other 37%. Thanks.
Thanks, Liz. So I'm sure we can build that into the narrative going forward. Just on that last early intervention psychosis, the national threshold 60%. So we are above the national threshold, but I understand you want to see a little bit more information about the sort of tail of people waiting beyond that. So we're happy to provide that, and maybe Tonya might also want to contribute specifically on that point.
I think the difficulty is we are talking very, very small numbers. So we're talking single digits at any one time, and a lot of this, so there's not an average length of stay but wait above the 2 weeks. And the patient choice is a potential factor in this. So some people, choose not to have their intervention 2 weeks from referral. But what I would say is it's very, very small numbers that we are dealing with on a monthly basis, single figures for each borough.
Thanks, Tonya. So shall I take a question from Patrick and Vasa, one after the other, and then I'll get you to respond to that?
So mine was really a response to Liz. Thank you, Andrew. The SMA health check, the annual SMA health check, by definition, is not it cannot be virtual because it involves blood tests. So as an absolute minimum, there's going to be an appointment with clinicians in the practice, but some of it can be done virtually. But there is integral to it is a face-to-face.
Vasa, do you want to come in?
Thank you, Andrew. Mine is not a question. Mine is to actually support what Jonathan just said about the scrutiny on the people who are waiting for a long time on the waiting list. All clinical networks of South West London ICS also look at the same thing on our regular meetings, as in our clinical meetings with the consultants and primary care managers. They go through this list. And Jonathan, one of the other things to highlight here is that South West London supports other London trusts, because we, for the sake of patient safety and fairness to patients outside South West London, if somebody else is waiting list longer, we do provide mutual aid, and that is fair, and that is what we should be doing. So I think it's not a race for us to try and bring our numbers down as fast as we can. We got to support others as well, because that is fair and equity for everybody, and that's what we do. And that's what we do.
Thanks, Vasa. Tonya, your hand was that back on SMI health checks?
Yeah, I was going to say, because it's quite an innovation, actually it does remove the need to have face-to-face, because you can collect data on the 6 metrics on a web base, and it goes straight into EMIS record, and it does count towards the I'll email to Liz with more detail about what it's called.
Great, thank you, Tonya. Okay, look, really good discussion around that. Thank you, everyone, for your input. Thank you, Jonathan, and your team for the report as well, particularly. So we've noted that. Should we go straight on then to the Primary Care Commissioning Committee report? So, Susan, do you want to just quickly...
Yes, I was going to sort of highlight a couple of areas, really. Just to say that the committee had a really helpful discussion around the quality surveillance report. We noted an emerging quality dashboard that's coming out to help PCNs, practices, local primary care teams to monitor quality. We also recognise the level of diligence that the primary care team put into working with practices, particularly those that have faced remedial notices and perhaps over the last 18 months haven't been able to make progress in quite the way they wanted to. We also looked at the opportunity for stronger links we made with Healthwatch in capturing patient experience. So that would be an additional bit of an element that could be added into the monitoring process. And interested in having future reports that looked at some of the common themes and issues that practice having, so we can understand trends and strategies in place to overcome these challenges. We also considered in detail the results of the GP survey and how this is being used as one of a number of indicators to monitor practice performance, which are then added in to the interventions that the teams are supporting practices with. And we had some feedback from borough teams that in spite of the significant pressures being felt in primary care, there are some really positive responses taking place to deal with the rising demand, whether both digital and face-to-face. The way the PCNs are working together, reach out to stakeholders in the community, and how we're managing communication with patients and making sure practice staff are kept safe and well supported when people are feeling rather troubled at this time. So thank you to the primary care teams for all the insights that they gave us at the meeting, a very helpful overview of what's happening in primary care.
Thank you, Susan. So are there any questions on that? No? Okay, seems clear. Thank you very much, Susan. So let's go straight on to the Remuneration Committee report. David, over to you.
Yes, thank you, Andrew, and for the board to note that I chair the Remuneration Committee with other lay members. There's two proposals here that have already been discussed in part 2 of the board, and also just to note that one of these proposals does affect executive directors who are part of the board, and therefore if there are any comments or questions, they clearly can't take part in this discussion. So we just need to note that conflict, Andrew. So two proposals. The first one is that there should be a 2% payment, which is to very senior managers. This isn't all of them, because there's a couple of them who are not who are excluded from this. But it would be to pay 2%. It's non-consolidated and it's non-pensionable for those members of staff, and it's in recognition of the fact that the support that they've had to give during the system during COVID, the vaccination programme, and also the subsequent recovery. VSN, very senior managers, haven't been given a pay award. And just to note that all of the CCG staff who are on Agenda for Change have. So this would be in line with what has been given to other staff. Although for other staff it's a permanent pay award, this would be a one-off. So as I said, that is the proposal, and that has gone through part 2 of the board and has been approved. So it's for ratification by the board here in part 1. So that's the first one. The second one, which again similarly has been through part 2 and has been approved and is for ratification, and that would be to pay a 2% allowance for on-calls to staff who are on band 9. And that's because, well, clearly, as we've heard earlier, when we were talking about the arrangements for emergencies on call, we have to have that level of robustness and resilience in the system, and that falls to those senior people. And it's also because of the previous system where there's been that on-call has been provided by the CSU, by the Commissioning Support Unit, and that is coming to an end. So we have to put in place an alternative system. So the proposal would be that 2% allowance to those managers who are on-call on band 9 and providing that service. So again, that has been through part 2 and it's been approved by part 2 of the board. It's for ratification here. I'm happy to take any questions, as indeed Sarah Blow may wish to as well, but it's for ratification. So thank you, Andrew.
Thanks, David. Really helpful. And just to note, of course, that none of the affected directors were in the Remuneration Committee, nor in the Part 2 discussion, because we asked them to leave for that discussion, so we're able to talk about it without anyone who's conflicted being part of that discussion. So obviously, the remaining members of the board in Part 2 did agree that, and it was to approve what was recommended by Remuneration Committee. So I don't know if anyone had anything further to say on that or any questions about that. Okay. Well, I'm happy to ratify that because you've already approved this in part two, but we wanted to do that in public. So shall I confirm then that we're ratifying that decision? Okay. Right, straight on then to the public questions section. I haven't had any, we didn't get any in advance of the meeting, and I don't believe we've had any sent through during the meeting, which is unusual. So I don't think we've got any questions to take in this section, unless you tell me otherwise, Ben.
No, that's correct, Andrew.
Okay, in which case I haven't been notified of any other business, so I shall draw the meeting to a close. Thank you everyone for your time and your participation, and I think the quality of the reports was really good, which helps us with our discussions, and it reflects the good work that's been going on, so thank you everyone. And let's close the meeting.